Good afternoon, everybody. We'll call the meeting to the JPS Health Network Governance Committee to order. Thank you all. Sorry for being a little bit delayed. That's what happens when finance gets us off track when they actually end early. So we'll figure out the logistics of that later. Are there any citizens wishing to address the committee? Seeing none, I'll move for approval of the June 28th minutes. Got a motion and a second. All in favor, say aye. Aye. Any opposed? Seeing none, it passes. You'll notice today that we're without CEO Robert Early. He's on his way back from Nashville, where he accepted an award, a very prestigious award. I believe only 4 people in the country were awarded this award this year, and was inducted to the Firestarter Hall of Fame. That seems like an award I probably got when I was 10 or 11 as a pyromaniac, but we're real proud of him, and we miss him today, but I'm sure he will be thoroughly caught up. With that, we'll move to Ron with an ERM update. Oh, I'm sorry. No, I'm working off the old one here. No, first is a discussion of appropriate communications regarding the upcoming bond election. I know that some communication was sent out through the board portal, and you've all seen that, but council's here and would like to brief us on that.
Yeah, I sent out an original opinion on, I think it was the 17th, and last week, and then I sent you a substitute opinion where we added some additional clarifications, sent you a clean copy and a highlighted of what was changed from the original opinion. The opinion speaks for itself. I think that with the questions Scott Rule reached out to me that some of the C staff members had that we added clarification even in the first opinion before it went out. And then we've some additional clarifications. So, you know, it comes down to a couple of things, and you've got the opinion, Scott and Robert have that, and I know they're sharing it with appropriate staff. Is the key thing is if you are on hospital from a board member standpoint, or if you're an official meeting or you're an official act of the board somewhere, then and that's going Charlie's going to probably have, and Chuck and DT, who are officers, are going to have to watch that probably a little more closely in terms of whether they're officially at a meeting in their capacity as an officer. But if you're not, then you can use your title as long as you use your own resources or resources other than the district. Many times in these kind of, and I think there is going to be some of them many times in these kind of campaigns, there's a Citizens Political Action Committee formed that raises money to pay for educational resources to promote the bond. That would not be a source of the district. That's a totally independent source. And so, but as long as you are on your time and you are spending hospital resources, then that can only be an education situation where you're educating the public about the facts of the bond. Their article in the Business Weekly, if some of you saw that, there was a 2-page article that laid out the Blue Ribbon Committee and what they had proposed. Those are perfectly permissible approaches to share with the public. You know, here's the Blue Ribbon Committee. That's what an independent group of citizens that came back and recommended to the County Commissioners Court. If in one of the key clarification that was in my August 20 substitute opinion was the question is, if you're on your own, using your own resources, can I use my title? And absolutely. Whatever, you know, you're a member of this board and you're using your own resources for your own time, you can be an advocate. You can encourage people to vote for the bond. So that's really the legal differentiation. If you, and unlike some statutes, this particular one, as I outlined in the opinion, has criminal sanctions if you violate it. And there's been some school superintendents and some city and some mayors and some board members and city councilmen and county commissioners around the state that have had to face that in past, and some of those opinions are cited in my opinion, some of those court opinions. And so, if you got a question, as I said at the end of the opinion, if any of you have a question, just pick up the phone and call me. You guys call me all the time on my cell, and I'm available, and if you got a question, call me if you're in a circumstance that is not clear from my opinion. So, yeah, any questions? Yes, sir.
Yeah. Let me give you a quick scenario.
Sure.
Dorothy and I were both invited to a meeting not too long ago. So we were invited because we sat on the JPS board.
Okay.
Okay. So at that meeting, now, bond didn't come up, but at that meeting, what's my parameters?
I think if you're invited to a meeting and you're invited because of the position you have on the board, you're in your official capacity. You can, at that point, you can answer any questions that are factual in terms, and I would encourage you, if you have the Blue Ribbon Committee, they've got an executive summary of that, and it outlines the various proposals, and I think it's on one page. I'd stick that in my pocket or on my desk. That would be my mantra to say, this is what they came out with, and this is what this $800 million bond election is to address those issues. So, but I think you got to be careful. Again, it's got in that situation, even though you weren't there for the bond, you're still there in your capacity as a board member. If the bond thing comes up, issue comes up, then I think you can educate. And if you're not sure, just say, hey, let me get you some materials. And I think there will be materials developed. In fact, I know there will be. There'll be materials developed. J.R. Labby's involved in that with G.K. Manus's office and developing some, and as well as Brian Epstein, the local pollster and political, that he's been involved in helping folks develop those kind of materials. So always defer on the side of, hey, let me get you something. And again, call me, okay?
I'm going to team up with Warren, and we're going to go through Arlington.
Well,
Yeah.
my advice for everyone would, you might could pick a different board member to team up with.
Well, I was going to say Warren, when he goes out to support this bond, can scream out his sunroof, vote for the bond, but he can't do it in a JPS van.
Okay. I agree. That's a good example.
Well, it is kind of a sensitive topic, one we need to certainly be cognizant of over the next 2 months. Go ahead, Dorothy.
Well, I know they are developing hopefully a communication information packet for us. Do anybody know when we will get that? Because I'm already getting questions and.
It's interesting because I asked JR after the Finance Committee meeting about a packet, and she said, yeah, we're putting it together. I said, well, it'd be good if you maybe brought that to board meeting and presented that. So she said she would do that.
I would tell you to work off the information from the Blue Ribbon panel at this time until
you get it, but I understand there is information like that, Dorothy, being put together.
Yeah,
So,
yeah, Neil, I'll just say this, as board chair, yes, there's elevator speech being prepared. Even in this environment, who prepares what and who can tell us to say what, and you're giving us a general counsel legal opinion right now, so I'm not saying who's preparing, how it's being prepared, but I think there will be some communication being put together that all can use, so we're kind of on the same page. I'm not page on that we're advocating, but presenting the same factual information, I think is probably the way to say it. So something's forthcoming.
Right. Because I know most of the folks already have the Blue Ribbon
Right.
recommendation, so they're asking you questions in relationship to that. So I want to make sure that what I'm saying is something that we've all kind of vetted in, so I won't be out there saying, oh, yeah, and then Warren said, now, Dorothy, did you tell those folks that? Did your reporter call and tell you that?
Warren would do
So, I
that.
mean, I just think it's a
Yeah,
key that we have it.
You're exactly right, Dorothy. And I think at the end of the day, I think a good, I hate to use the word cheat sheet for the time being, is, I think Neil indicated the Business Press had a real good article about it, and they took their excerpt straight from.
And JR was involved in developing that article, as I understand it as well.
I can always tell.
I don't use a JPS email address, but is it permissible for somebody to use the JPS email address in the advocacy, or do they need to use their own email address?
They can use the email address for educational purposes in terms of the employees, but they cannot use it for purposes of advocating to vote for it. So in terms of, and as board members, I would advise that if you've been issued an iPad from the district that you're using, that you use another vehicle, your own personal laptop or iPad to do whatever you're going to do related to the bond, okay? Okay.
Any other
Call me if you
questions
need me.
regarding the bond?
Okay.
I would tell you, if it feels strange, do it. Probably don't do it. If you have a question, urge on the side of caution.
Yes. Right.
Yep.
All right, we'll move on to item number 6. Ron, start us off, sorry. Yolanda, if you want to come on up too, you're going to be next. Might as well be ready. It'll be Yolanda's first time to present to us.
All right.
And Michelle is on vacation. She told me she would watch this meeting from the beach someplace, and I told her that I would be really
Yeah,
mad if she did that.
Sure.
No, she is. Hi.
Yeah, sure.
I guarantee you, it's on her cell phone right now.
Well, tell
Warren,
her.
how many people are on? There's probably 8.
And we're having Diet Coke. That's right. And we're having Diet Coke wherever beach she's on someplace. I'm quite sure she is.
And I did tell you, when I was going through the meeting with Yolanda and Ron and everybody, they did threaten us with staff doing skits to show us what we could and could not do in regards to the bond issue, but fortunately, Neil saved the day. We don't have to do one-act plays, so. Take it away, Ron.
Okay. Good afternoon. I'm going to start with the ERM update. What I decided to do this time on the ERM update, let me make sure on the right slide here. Okay. I'm going to provide some activities and headlines since our last governance committee meeting that we've been doing in the ERM area. One of the things I mentioned at a prior meeting was we've had a lot of discussion about the 10 or 11, now 11 with cybersecurity areas of focus for enterprise risk management. And so one of the things we talked about was, when do you reassess and when do you look and see where we are relative to where we'd like to be? And what was discussed is that we would reassess these on a 3-year cycle. We're in the end of 2 years on all 10 of these, and so we have one more year on the original 10, and then we have the cybersecurity one that just started this year. So next year, and it kind of goes into my third bullet point in terms of fiscal 19 ERM program development, is to do a refresh of the ERM enterprise risk assessment, certainly against the 10, but also, it's 3 years is a long time. So are there others like cybersecurity or others that we want to put on the list as areas of focus? And so that will be prominent for this upcoming year, working with the executive and team members around where are we with the 10, and that also includes the new executive leaders, which is my first bullet point. So I've spoken with Dr. Hochberg and Zelia and Dr. Kramer and Dr. Nakaris about their vision around those areas that their predecessors had given me input on. So we're in the process of doing that. We also conducted for the first time a ERM risk survey that we sent out to all JPS managers and above to get their input on with several things, so their areas of risk as well as their familiarity or agreement with certain key questions. And I have a slide on here in a minute that I'll share that with you. And then lastly, as far as headlines go, one of the things that I know was discussed in the past was, how are we trending and how are we being JPS, how are we doing in terms of the areas of focus that we focused on, these 10 or 11 areas, relative to what others are focused on, relative to benchmark or other data. And so I have a little bit of that information as well. Starting off with these couple of headlines that deal with a couple of our areas of focus. One relates to patient experience in terms of an article around what emergency department patients want during their hospital stay. And looking at the 10 things, and which include caring and empathetic demeanor by the caregiver, communication about their comfort, communication about their results, communication about their medication and pain management in particular, communication about their food, communication in layman's terms that they can understand, and then communication, both verbal and nonverbal, about their care plan after they leave the hospital. All of these areas I know are areas of emphasis, not only in the rounding that the caregivers give on both the nursing and the physician rounding, but as also there are, in several of these areas, there are task force around them. And so this is just a reminder that this is something that, certainly is still a very much of an area of emphasis in healthcare, particularly in the emergency room. The second one is a Joint Commission newsletter called the Sentinel Event Alert that talks about a growing trend about violence in healthcare settings. And I know Robert has talked about this topic in the past about the growing trend of violence against healthcare workers. And this article speaks to the fact that this is a nationwide situation. And actually, the Joint Commission cites a data point from OSHA that says that approximately 75% of nearly 25,000 workplace assaults reported annually occurred in healthcare and social service settings. And that's a pretty alarming rate. And so I know one of the things at JPS that is being done around this is a task force to develop a plan of how we deal with these violent patients, and also it goes hand in hand with mental health. And we've talked to Zelia and their folks their folks are part of developing that plan. From an enterprise risk standpoint, this falls within the area of authority and accountability because it really speaks to the workforce. And are we doing enough to keep our workforce safe, but also creating a safe environment? And so, we've also seen some of those situations here at JPS, and so that's a growing trend and also a concerning trend as well. Before I go on, are there any questions about any of that? Okay. The next piece on this slide is a national survey that was done by the National Association of Corporate Directors. And NACD is an organization that comprised of board members of both public and private entities that talk about various events. And they did a survey in 2018 this year. And one of their survey was, these are the top 5 risk trends that board members of both public companies as well as private companies across the country opined on. And there were about 740 board members and C-level executives that collaborated on this survey. And these 5 are the 5 risk trends. Cyber risk we've talked about a lot. I don't know if David is here, but we hit that one pretty good last time. Certainly that's an area of focus. We talked about it also in finance in terms of our cyber liability coverage. But 59% of the 740 board members that took this survey cited that cyber preparedness was a significant concern for them. The second one is regulatory amendments. That one kind of goes without saying. That this one was cited by the survey respondents around political uncertainty, as well as the tax reform that passed not too long ago, as well as the increased regulatory burden. And certainly healthcare is behind financial services is preeminent in terms of that change. And so a lot of the things that we talk about in compliance and specifically deal with these regulatory changes, regulatory amendments, and how are we complying and adhering to them. Talent acquisition, I think Steve is gone, but he talked about the fact that with the unemployment rate being what it is, the talent and competitiveness for talent is extremely high, particularly for skilled clinicians and physicians, and certainly the claim folks can speak to that. And that poses a certain level of risk to organizations in terms of not getting the type of talent that you're looking for. Economic developments. What was cited here was in terms of this one, what was cited deals a little less with healthcare. They cited some of the trade talks in terms of the tariffs and other things that are affecting business kind of on a global basis and across the country, as well as unexpected events like what happened in 2008, 2009 in the financial crisis. And then lastly, this one is particularly relevant, I know for us, is technology and innovation disruption. So just the speed in which technology is evolving, the disruptive nature of it. I know within healthcare, the telehealth, the consumerism movement in terms of people being more aligned with how they spend dollars on healthcare, and the trend toward high deductible plans was also cited, as well as an ability for the organization to change with the rapidly changing environment. So what was cited is interesting, is that there is a recognition that this disruptive change is happening, but there is less confidence by some of these board members that the organization is ready to adapt as quickly to that change. And obviously, some of these companies that were part of this have, are filed bankruptcy. So, there are companies like, Toys R Us, companies like others that kind of have been disrupted by Amazon and other kind of companies, but certainly within healthcare, the M&A aspect was cited as well. So I just thought this was interesting, just to kind of give a perspective to how do the things that we're focusing on, these 10 or 11 things, compare to what other board members and other, within and without healthcare are looking at. Well, where should I start? Top three. Okay. Well, I would say one of the seminal ones, I'll start with compliance, was the Affordable Care Act and all of the components of the Affordable Care Act that had tentacles on how we do business. And so one of the, oftentimes what we focus on in compliance is, are we billing appropriately? We've talked about that in terms of is our documentation, and that has evolved over time. And so the evolution, particularly with the enforcement of the False Claims Act, which is not new, but is new in terms of kind of how vigorous administration is enforcing it, is that in many cases claims that are overpaid by government payers, and I know our mix is different than a traditional, just a standalone acute care hospital, so we don't have as many Medicare and Medicaid patients, but we have some. But particularly government payers like that, if there is any error or omission, and there is a tendency by the government to consider that to be a false claim, even if it was an error, unless there's evidence to support documentation. And so many of these headlines that I mentioned in these slides are generated from increased government enforcement, which would fall into this area. Now, obviously, one of the things we also talked about was 340B in terms of the changes that are still uncertain as to what the government wants to do with reimbursement around that and how significant that is to us, or another example. Yeah.
Anything dealing with the government.
Yeah. So this is the first time that we've done a survey of JPS managers and above, and it had some interesting results from that. And we had 305 managers and above, including the executive group as well, that were surveyed. Of the 305, 226 responded to the survey, which is a pretty good response. And these are kind of some of the high headline results from that survey. 82% of the respondents indicated they agree or strongly agree with the statement that JPS cultivates a culture of sharing best practices, which is good. That's a fairly high percentage. Now, obviously, it's not 100%, so there's still opportunity there in terms of how folks feel like how we're communicating with one another. 97% agree or strongly agree that they are familiar with the JPS goals and metrics. Now, keep in mind that this group is all eligible for the AIP, and so it's not surprising that they're all familiar with the goals and metrics, as there's a bit of an incentive for them to be so. But it also says that they are focused around it. 97% also said that they agree or strongly agree that they are effective in managing department-specific risks in their specific departments. But interestingly enough, the 82% indicated they agreed or strongly agree that we as an organization are effective in overall risk mitigation strategies. And what that tells me in looking at the specific data is two things, is that 82% is not a bad number, but what it indicates is there may be some opportunity for people to understand what they are doing in their departments and how it fits with the overall approach and what JPS is doing overall. How do they fit into the bigger picture? The other thing that it tells me, just from a human standpoint, is that them saying that they are effective, I'm good in my department, is a bit of a bias, because they, I'm good in my department, but I don't know what everybody else is doing, type of thing. And so there's a bit of a bias there that I would probably assert in terms of that. The other thing I would say before I go off the slide is that we also gave them an open-ended responses of them saying, what do you foresee, what do you view as risk in the organization overall? And the responses were too voluminous to go through, but I did summarize them into kind of general themes in their open responses. And the top, I'll say the 5 most mentioned responses in the open responses were cyber risks, physician engagement, our ability to accommodate needs of the community, revenue diversification, and expense management. And so those last 2 don't surprise me, given how close we are out of the budget cycle. And so there's been a lot of focus on individuals around expense management. But we had some really robust responses, and many of them were very detailed, so I was very happy with the response rate. So I'll stop there unless there's any questions. That would end my ERM report.
Thanks, Ron. I think a 75% return on that risk survey is, for the first one, is a pretty remarkable number. And I think that these numbers give us probably a pretty good baseline as we go forward and continue to roll this out. So certainly that 82% effectiveness in risk mitigation strategies gives us a pretty good baseline and to go up from there.
Absolutely.
I'm glad the number's not lower, but it does to me show that, yeah, I'm doing great, but these other guys, I don't know about these other guys. So.
Exactly.
But I think that gives us something to work on. Thank you for that.
Absolutely. Moving on to the compliance program report. I'll start this off, and then I'll turn it over to Yolanda. Just touching on a few key compliance headlines since the last time. MD Anderson in Houston was recently fined $4.3 million in civil monetary penalties for violations of HIPAA. Much of this fine was generated from a lost unencrypted laptop and unencrypted thumb drives that were used for research purposes at MD Anderson. And they contested this with OCR, and their argument was that since this data was used for research, that they should be exempt from the fine. And so the judge didn't see it the same way, and they upheld the fine. And this was going back to a 2012 breach for MD Anderson. It just got adjudicated in 2018. So it's been all these years that it's worked its way through the contest. But it was a breach of 33,500 patients with an unencrypted laptop and 2 lost thumb drives that were lost back in 2012. So again, this is just to reinforce that this is ever vigilant area, and I know Yolanda will touch on this a little bit as well, of how we need to coordinate with David and Melinda's group, and as we currently do, to do these audits and social engineering around that. The next one is around a settlement, a very large settlement, over $15 million for fraudulent Medicaid providers that the Attorney General Ken Paxton was a part of, and so this was probably a broad sweep of several providers that basically were overpaid by Medicaid for rehab therapy providers specifically that were false claims and were basically fraudulent claims that was determined over a period of time. And it was not just one, it was several, and there were several named physicians as well as organizations that was a part of this. So again, we mostly talked in these about about federal sanctions, which the OIG and HIPAA is federal, but in this case it was enforced by the state, and it was again a very, very strong enforcement of the false claims, as well as looking at abuses that happened with Medicaid that still happen. Memorial Herman's back in the news, unfortunately. They were hit with a $2 million HIPAA fine as well for, actually, I take that back. I want to, I mentioned this one before. This one might be, this one was the one I mentioned before related to the press release that they had sent out indicating that they had caught a person who was trying to do identity theft. And when they did the press release, they put all the information about the individual and the patient information in the press release. And so the press release itself was a breach, which was what was determined. So I did mention this one before. My apologies on that one, but you know, that one deserves a top 10, I think. This last one is somewhat. This last one is somewhat topical. It's Maverick County, which is in Texas, had a bond election, and the elected officials in Maverick County were advocates of the bond election, active advocates of the bond election in their capacity as elected officials of the county, to basically raise an $8.5 million bond for Maverick County, and they were sued for violation of Chapter 255 of the Texas Election Code, and for doing that in their capacity as elected officials. And you know, I actually have photos of what they did. They actually have signs and placards on trucks and other in both Spanish and English supporting the bond election. And just so happened the voters voted against the bond, and it was defeated. And it was a lot of commentary and a lot of angry people in the county around what the elected officials did in that particular case. I'm not sure. That's a good question. Yeah. Warren, is this your handiwork right here?
And I would deny.
Yeah. Yeah.
It's got to be a it's got to be a Texas county,
Yeah.
something named Maverick.
Maverick, yeah. Eagle Pass, you say? Yeah. So,
The ethical violations are filed with whom? Is it with the Texas Ethics Commission?
Yes.
But that's just been a complaint made, right?
ethics violation complaint, yeah. With the Texas Ethics Commission, yeah.
I don't know. Imperial boys out there, Maverick, I don't know about
We joked in the meeting, I want to know where all the big,
In that county, I suspect the county attorney and the county commissioners were pretty close. That's probably the reason the complaint went to the Ethics Commission.
Yeah.
I want to know where all the fine money goes. There's got to be a big hole in the ground where all these fines and penalties are dumped into, because nobody, that money is gone.
Well, that 4.3 million, probably 4 million of that is which is, of course, Justin, right?
Mr. Chairman, you're losing control of your
Yeah,
committee.
so I'll move on, yeah. All right,
Chairman's been advised he's losing control.
yeah.
Good afternoon.
Here you go. Oh, you got one, Mr. Okay.
This is my first time reporting to you guys, so feel free to interrupt me, ask questions, and I'll be more than happy to address them. My task is to review the compliance program updates. I'm going to give you some high-level updates regarding the 2018 compliance audits, particularly those that are listed below. Talk a little bit about the risk assessment process for the 2019 work plan, and then actually present to you the proposed 2019 work plan. So the external audit that I want to mention to you guys is the Health Resources and Service Administrator. We refer to them as HRSA. They are a federal agency. They basically are the agency appointed to oversee the 340B drug pricing program, which is very important to JPS and many of the hospitals throughout the United States. But they're responsible for doing audits, and they came in and they did an audit maybe, 2 months or so ago. and we're still pending the outcome. Just like with any government audit, the results come a little bit,
2028.
exactly. We're maybe by the first of 2019, hopefully.
They don't give you sort of a summary when they leave?
No, HRSA doesn't, but we had Poneman, who's the consultant that was there when HRSA was there, gave us a kind of a high level, because we engaged them to do this, who gave us a high level summary, and they believe that our 340B program was in good shape. They're obviously they're going to have a few things here and there, but Poneman let us believe that we didn't have a lot to be concerned about. So, but we haven't got the official report. So, yeah.
Thank you, Ron. And the next audits I want to talk about are the internal audits. And one to talk about the coding modifier follow-up audit, which is completed, and we'll talk about that a little bit more. And then the modifier 59 and XU audit. Both of those audits are underway. I do want to make sure that you guys are aware that those modifiers are very important, because when we're submitting a claim to Medicare and Medicaid, those of our government payers, and we don't get a free get-out-of-jail card, when we append those codes to a line item service, it tells them to pay us more money, that we did more services and we deserve more money. And so that's why making sure that we follow up on the previous audits that were performed in 2016, and that's what these audits are follow-up, to make sure that the corrective actions that we agreed to are being met.
What are the two items? What does 25 mean? What's 59?
The modifier 25 is a modifier that it means that there were separate services rendered in addition to to a clinic visit. The 59 modifier XU basically says that there were separate and distinct services provided to a procedure or other service. So, and it says because of that, then we deserve additional payments. Great question. So regarding the the proposed work plan for 2019, I do want to just give just a brief overview of the elements of an effective compliance program. Back in the 90s, the Office of Inspector General started issuing compliance program guidances, and hospitals all over the United States began to adopt those guidances. Additionally, the United States Sentencing Commissioners, they also adopted those guidances to help mitigate any type of criminal penalties that could come down. So these guidances or those elements are very important to any compliance program. JPS also adopted these guidances as part of their compliance program. When we talk about the work plan, we primarily talk about in this session regarding the monitoring, auditing, and internal reporting and risk assessment. But it's very important for you guys to be aware that all of those elements, that we're working to achieve those on a day-to-day basis. On the other side of that slide is just a review of, just to let you know how we determine our risks and how we assess the risk. And so what we normally do is look at our internal audits that we performed. We looked at any reported concerns, and then we apply a risk assessment process to that to determine if it's high risk, low risk, or in between. And the same thing for the identifying external risks. We particularly look at the ORG work plan and their compliance reviews, which they publish routinely. We also look at a lot of the CMS reports, which is very important to us. CMS has a report where they are now looking at the emergency room clinic visits that are billed by hospitals, and we'll talk about that shortly. And then we just mentioned HRSA. HRSA oversees the 340B program, and of course HIPAA through the Office of Civil Rights. Any questions? So on that framework, I want to submit to you for your approval the proposed 2019 compliance work plan. And the work plan basically consists of those issues that are listed above. But before I start reviewing those, I do want to make you aware that in last year, the Office of the Inspector General, or OIG, they decided that they would no longer update their work plan on an annual basis. They said that they would start updating their work plan as needed. So this work plan that we have here will become more dynamic so that we can be responsive to any new work plans or initiatives that are added to the government's work plan. So it's subject to change. I just want you to know that up front. The emergency room department services, we will particularly be looking at all of the different emergency department areas, which would be the main ED, the OB triage, behavior health, and urgent care. And we will look particularly at the hospital billing of those clinic visits, not the physicians. Regarding the modifier follow-up, I've already mentioned that. We want to make sure that we complete that 59 XU, XE, XS, and XP audit, and we hope to get that audit actually completed at the start of the new fiscal year. The intensity modulated radiation therapy follow-up audit, that audit was reported during our last meeting, and we want to make sure that the corrective action plans that were agreed to are being done. And we also want to make sure that any identified overpayments are refunded. Part of being a provider that participate with the Medicare programs, we agree that we will identify any overpayments, and we have 60 days once they are identified to refund those. This audit consists of 86 accounts or medical records. Of the 86, about 23 of those fall into the government payer. So we want to look closely at those 23 to see if there's any overpayments, and I suspect there's probably some opportunities as well. But with the government, we can't balance out. We have to refund the overpayments and eat the unders. It is what it is. And we'll look at inpatient. We want to make sure that we are on top of making sure our inpatient stays, particularly those short stays, 1 day, 2 days, and 3 days, that they are in compliant with medical necessity. The Emergency Medical Treatment and Labor Act, that is a very, very important act for every hospital in the United States, and that definitely includes JPS that has an emergency room. That act basically says that anyone that comes to the emergency room, that the hospital has to provide a medical screening examination, treatment and stabilization, regardless of who they are or their ability to pay. So we want to make sure, one, that we have all the applicable policies and procedures in place. We also want to make sure that when patients are being transferred to us, that they are meeting the letter of the law. That's very important to us. This law actually was called the anti-dumping law. It had a lot to do
You're talking
back.
about the patients coming from other facilities.
Correct.
They had that treatment prior to coming to our facility.
Yeah, if anyone went to and I'm getting used to all the hospitals here, like a THR, a emergency room, and let's say
Let's call it Hospital A.
Hospital A.
Theoretically.
Theoretically.
There's 8 people watching on YouTube.
Theoretically, if someone went to another hospital and they went to the emergency room, and let's say that they started asking them questions about their ability to pay, and they walk out and they come directly here. And they come to our emergency room. We're going to apply the regulatory requirements. We're going to see if they had an emergency. And our processes now we're working on to make sure that any suspected patient is reported up, so we can do the due diligence to ensure that every hospital is being held accountable for meeting the EMTALA requirements. And so we're also looking at the flip side as well to make sure that when we're transferring those patients out, that we're meeting the letter of the law as well. It's about accountability. And regarding the HIPAA, we also had Dixon, Hughes, and Goodman in to do a mock audit, and we're actually still waiting for the finalization of that. And with that one, we'll fine-tune the issues and scope for the HIPAA and for the business associate reviews for 2019. Now, earlier I mentioned the 7 elements, and so I mentioned the fact that we're going to a more dynamic audit plan. So what we want to do is make sure that when we think that we have some risks or concerns, that we perform probe audits. And so we've identified some areas that we definitely want to make sure that we perform a probe audit, and that's between 5 and 20 charts. And doing some data analysis to determine whether or not there's any true risk there. And if it is, then we can determine whether or not it will move to the audit plan or monitoring. Any questions about any of those?
I have a quick question. well, to really, the significance of the red in these charts is that, that they're undone and not complete? or-
That's a very great question. The red actually meant that they fell into a high-risk category.
Okay,
And the yellow there, or gold, meant that the business associate agreement fell into a medium category. Anything that fell into a green, it's good.
okay.
So as a part of our risk assessment process, and you'll see this in a moment in the internal audit section as well, the inherent risk of each of these areas was assessed based upon significance and likelihood of these areas and their impact on JPS. And so there's a chart and scale that drive the color. And so that's kind of how that was determined.
We see thousands of these things with different color codes and charts. It would be so beneficial if there was, like in the front of the packet, this is what red, green, and yellow means.
That's a good point.
in this
Actually, we had it
particular
on
chart.
here. I don't know what happened to it. It was there.
Yeah.
We had a legend there,
Yeah,
and I apologize.
that'd
It
be
must
great.
have gotten
I'm an Aggie, I
removed.
need as simple as humanly possible.
Maybe.
My other. Yeah, we will in just a second. Yeah.
Yeah.
My second question is the compliance work plan, number one, the emergency department services. This particular scope deals with the facility billing, and we kind of talked about that. The question came up was, how are we, in dealing with the claim, does this governance committee look at their audit reports? Where's the accountability between the two? Are they completely on their own? Do they report back to us? Because this is one side of the equation. There's a doctor side of the equation that looks just like it.
Yeah.
So,
I'll address that. I know one of the things that's over the last several months that has occurred is a claim has its own compliance committee. And Dr. Hurd, who was here earlier, is the chairman of the Acclaim Compliance Committee. They also have three, I think now, compliance staff, Sandy Routley, Christy Benson, and I forget who the new person is, that do ongoing physician chart reviews to determine whether physician billing chart reviews are in accordance with compliance standards, similar to what we do on the facility side. We get consulted around their development of their compliance plan because Acclaim has a compliance plan that we are a part of in terms of developing, and they meet with us monthly to give us updates on kind of where things are. I think you brought this up when we were meeting before, and that is, can we include in our information here to this governance committee the Acclaim kind of results? And I don't see why not. And so I took that as a note to do that. I'll get with the Acclaim folks and coordinate that.
okay.
How about an alternative, which would be they report to the Acclaim Executive Committee, and then that would be part of the presentation that Acclaim would make to this committee instead of.
Yeah, that's
That
another
would,
idea.
that would probably be more in accordance with the bylaws, absolutely, yeah. Right.
Separate.
Yeah.
Yeah,
And
so that can definitely be done.
Sure.
Yeah.
Yeah. The main thing, when they get outside their processes, and we recently had to argue on some open records requests, that we want to be sure that they're treated as you recall, in 2015, we got an opinion from the AG that they are not a governmental entity, and we certainly want them to be, continue to not be. And so, for varying reasons, not just open records, open meetings, so.
Thank you.
Any other questions regarding this part of the proposed work plan?
I do have a question. I'm a little bit confused. Everything we've been talking about so far is for Medicare, Medicaid patients, correct? We talk about the different audits and whatnot. How do we look at the JPS connection patients? Do we treat them sort of as if they're Medicare patients and hold them to the same rules, regs? I don't know.
Well, I'll kind of jump in here. I think from a compliance standpoint, just from a regulatory compliance standpoint, if we look just strictly from a risk standpoint, the government payers have the highest risk because there are specific requirements in terms of overpayment, underpayment, false claims, like I mentioned before, tied to Medicare, Medicaid patients. Connection patients have the kind of the next tier of risk down. It's not that they get treated differently, it's more their risk, I'm just talking from a risk profile, not from anything else.
I didn't mean to say that they're treated differently.
Oh, okay. But how do we,
I would, let me chime in on that one if you don't mind. I think that when we start looking at, even though we focus on the Medicare and the Medicaid because of the reimbursement, when we look at our audits, we're looking at the audits from the requirements based on the local coverage decision, and these are the requirements that it should meet. We're looking to make sure that we're meeting medical necessity for inpatients. So anything that we identify as a corrective action plan applies across the board for making sure that we're compliant across the board. We just use the government payers as our framework.
Okay, so, but you do actually pull JPS connection patient charts.
We would not per se pull their charts because they're seen by the same providers, the same rule applied to them for the documentation and the review. And let me explain that a little bit because it has always been that physicians, nurses, they really they shouldn't know what your payer is. They're there to provide care. So our framework, again, it's always based on the government because the provider of care should be providing care regardless of who you are in your coverage.
And I will ask it again, then part of your review should include some of those charts. That's all I was asking. Even though, yeah, we apply, but then when we monitor, we would look at just a sampling of all charts. So that was my question.
okay. I know in the IMRT audit, as you mentioned before, of those 87 charts pulled, the majority of them were connection patients with the exception of 23 that were government payers.
Any other questions regarding the proposed work plan?
Okay.
Wait a minute, did you say in that so many of them was JPS connection and they had overpayment?
No, I didn't say overpayment. I was saying.
No.
They were included.
They were included. Yeah, their dollar amount were either written off at, based on the percentage of their qualification.
If there's no other questions, we will need a motion and a second to approve the proposed work.
Oh, I'm sorry. One last comment.
Yeah, I was going to go ahead and indicate that part of that, we want to make sure that we're also doing those ongoing monitorings. And that's very important because they happen every day, like the monthly sanction screening for ineligible entities and individuals. That's a Medicaid requirement where we're monitoring to make sure that no one is employed, a physician is, no one is excluded from participating in federally funded programs. And so these are some of the activities that are occurring on a routine basis. I wanted to make sure was highlighted in the plan this year. And then secondly, on the other slide, just to talk a little bit about some of the program requirements that are also ongoing that help us meet those elements that we talked about at the beginning of my presentation.
Yeah. So what we did here, so we don't confuse you, is that in that table at the front are the 7 discrete audits, compliance audits, that you'll get a report out to this committee from compliance standpoint. And then these other 2 sections, the probe audits, the ongoing monitoring, and this last slide on program requirements. We've been doing these ongoing for a long time, and we're just indicating that we'll continue to do that because we're required to do so. And if there's anything that comes up as our part of our monitoring activities that falls out of any of these activities, then we report that to the committee. We just didn't want to get these jumped in with the discrete audits that we're proposing, is all.
Any questions?
I'd move for approval of the proposed.
Got a motion? Mr. Bo seconds. All in favor, say aye. Aye. Any opposed? Motion passes. Thank you. Thank you very much.
Thank you, Lonnie. Well, I'm going to pinch
You got a
it.
high bar here.
I have a high bar, I know. I'm going to pinch hit for Michelle. and I hope she's not watching from the beach.
I told her I would be mad at her. 7 viewers.
Right. So, really, the only item for internal audit is the internal audit work plan for fiscal 19. Similarly, Michelle's group went through the same process that Yolanda spoke about on compliance. This first slide just speaks to that process, that we had a number of interviews with leaders, board members included. We looked at financial trends, we looked at employee trends, vendor payments, a number of inputs that went into the risk assessment process. And one of the things she wanted to point out was that this annual risk assessment is a requirement by the IIA, the Institute for Internal Auditor Standards, that we do this on an annual basis, and that we met those requirements by conducting this risk assessment, this year as we have in the past. So this slide, similarly to the compliance slide previously, is just to indicate, this is the inputs that went into what you're about to see in terms of the internal audit work plan. So from an internal audit standpoint, we have 4 primary audits that will be new audits for next year in fiscal 19, and then we have several follow-up audits on the next slide. These first 4, the red again indicates that based upon the risk assessment, these have high potential risk to the organization, and the yellow is medium risk. The first one is pharmacy benefit management services, where we'll look at the Maxor Plus pharmacy claim payments, which roughly is about $9.5 million, and the administration of that, of the PBM contract, just to ensure that the controls are in place to pay only eligible pharmacy plan benefit members against that. And so this is more of an attestation or an assurance audit against the pharmacy benefit management plan and contract. The second one is around patient transportation billings, where we'll look at the controls around the accuracy of the ambulance, helicopter, taxi, and other forms of patient transportation against the invoices paid. Again, an assurance or a validation that we are paying for appropriate services, or we're paying for services that were rendered and that they are appropriate according to contract and invoices that were paid. The third item is sterile instrument processing, and this is a new area. And I forgot to mention, this chart also has a link to the ERM risk area that it relates to as well. And this is to evaluate the endoscope management, including leak testing, washing, rinsing, disinfection, the whole process around sterile instrument processing, as well as the quality of the training processes around this. And you might think this is a kind of a unusual one to include in terms of internal audit, but this has been something that has when we go to roundtables and when we look at our internal audit vendor, has been cited as an area that we probably would want to look at, and we have never looked at this area before. And in many hospitals, if this isn't done properly, this does bear very significantly on quality, as many of you know. And so this came from risk assessment interviews as well as trends. And then the last one is related to the physicians and to the ongoing professional practice evaluations, the OPPE evaluations that are done for physicians. This came actually up through conversations with some of the physician leaders that we had to validate the reliability, integrity of the OPP reporting process, looking at those dashboards that are provided to ensure that they meet the intent of the Joint Commission requirement, as well as provide meaningful feedback on performance. And so this one isn't as regulatorily tied, but it is equally important because the OPP evaluations are used to evaluate physician performance. And this also came through the risk assessment process. So for each of these 4 audits, there will be, Michelle and her team will have a separate report out to this group as we look into next year. Okay. The next slide is on the follow-ups, and there are quite a few. Many of these you've already seen before, so I'm not going to go through all 10 of these, but the team is going to be fairly busy in doing this follow-up. All of these on this slide, you have you have seen before in terms of prior meetings. And so, we're required to follow up on prior audit findings. The ones that are identified in red are those that have, as it says there, higher priority follow-up projects. So that means that there are audit issues that were identified that had been previously reported that are in the higher end of the spectrum, in terms of the higher risk of the spectrum, that will validate something has been done. And then those on the right are moderate to lower end issues related to those. Again, all of these are completed audits that are for follow-up. The thing I would mention, and is indicated at the bottom of this slide, is that the 4 audits that are bolded on this slide are ones that we've done follow-up activity in this year in fiscal 18, but still had open items that were not satisfactorily resolved, when we did our follow-up. And so they need to stay on the list. And so we'll have additional information in closed session related to those specific items. But one of the things that, as is required is, that we do appropriate follow-up. So between the 4 audits that'll be new, that you'll get reports on, and these 10 that will be followed up on with the internal audit team, these 2 things comprise the internal audit plan for fiscal 19. So I'll stop there and take any questions or seek approval.
Does anybody have any questions regarding the audit plan?
I understand why you say that there's going to be discussion, there will be some other issues. But the request now is for approval of proposed.
Of the 4 new projects and the 10 follow-up to go through for 19.
On the OPPE, ongoing evaluation, will that tie in to when they come to the board for us to approve their privileges? Is that, I'm just trying to figure out how that one will tie.
Well, we're not evaluating the privileging and credentialing of the physicians, but we're looking at the performance evaluation. So that and so we still have, the reason why we have this language in terms of the scope is that we have some latitude to work with the areas to kind of define it. So that, because oftentimes when we do these, we'll need to define the scope when we get closer to the project.
Yeah, okay.
But
I do see that term when they come.
Right.
OPPE.
Yes, but to answer your question,
point.
it is not going to include
It does
the,
not include
yes.
the part.
Yeah.
Okay. All right.
Any other questions? We will need a motion and a second to approve the fiscal year 19 annual internal audit work plan.
Move for approval.
Got a motion and a second? All those in favor, say aye.
Aye.
Any opposed? All right, got our marching orders.
thank you.
Okay.
Appreciate
Thank you,
it.
Ron.
Thank you very much.
And
We will
Yolanda.
adjourn now.
I'll tell Yolanda, thank you for her report.
We'll take a 5-minute break, and we
5-minute
will
break.
adjourn to a very quick executive session.
Hopefully so.
Yeah.
All right.
That's what you say all the time.
It needs to be. We're gonna
We will reconvene at 1:56 to open session. Being no further business or any action from executive session, this committee stands adjourned.